we're going to talk today about what non-motor symptoms in Parkinson's are and a little bit about our understanding of why they occur. And I'll give you some treatment approaches that we use in clinic when we're working with patients individually. So we know, and you all are aware, that Parkinson's disease is traditionally thought of as a motor disorder, but that's really not a full view of what Parkinson's is and what it causes. And so I'll just start by reminding us all how we diagnose Parkinson's, which still relies primarily on the motor signs. And we look for things like tremor, rigidity, akinesia or bradykinesia, which means slowed movements. And traditionally, we've talked about postural instability, meaning trouble correcting your balance if you start to lose your balance. But that's a sign that typically emerges much later in the course of Parkinson's, and we no longer use it to make a diagnosis as much because we don't expect to see that as early on. But these cardinal motor signs translate into symptoms that tend to bring somebody into the doctor or neurologist in the first place. So this is where the motor piece comes in, because this is what often brings somebody to our attention. So the tremor, obviously we all know what that might look like, that somebody might come in wanting to get that checked out. But many people don't have tremor, and they might present with muscle stiffness or a frozen shoulder or cramps or fatiguing easily when you're exerting yourself. And the slowness of movement can manifest as small handwriting, trouble doing fine motor tasks that require dexterity, like cutting food or getting your wallet out of your pocket, that kind of thing. And that bradykinesia piece is the thing that we have to see in order to make a diagnosis. So we really rely heavily on that. And then the postural instability, if it's present, can result in falls. What we understand, though, is that many years or even decades before these motor symptoms bring someone to our attention in the neurologist's office, these non-motor symptoms are evolving. And they can be thought of in a couple different ways. So there are non-motor symptoms that affect the central nervous system, meaning the brain and the spinal cord, and non-motor symptoms that affect the peripheral or enteric nervous system. And the enteric nervous system is our gut. So centrally, people tend to have a loss of sense of smell and taste, sleep changes that can occur, such as acting out dreams and talking in your sleep, thrashing around at night. Mood changes like depression and anxiety are quite common. Fatigue that's not correlating to lack of sleep. And even cognitive symptoms can occur before the motor. And then with the peripheral and enteric nervous system, it's very common for people to have experienced constipation or urinary and sexual dysfunction, even cardiac dysfunction, although that tends not to result in any life-threatening cardiac problems at all, but it affects the control over heart rate and blood pressure. So this figure is from a recent article, but I think it helps to illustrate, if you look at this 0 time point here, this is representing when someone might come in because they're developing these motor symptoms here. And we look back, and this represents 10 years before motor symptoms, 20 years before motor symptoms. In retrospect, these non-motor signs were already present. But we can't look at someone here who just has constipation and no other signs, and at this point in time recognize that they're going to go on to develop Parkinson's disease. It's only really in retrospect at this point that we can use these signs. Now, for RBD, which stands for REM sleep behavior disorder, it's a little more specific. So, there can be a million reasons why someone might have constipation, but if someone has a diagnosis of REM sleep behavior disorder on a sleep study, we know that there is a pretty high likelihood that they will go on to develop Parkinson's or a related neurological condition like Lewy body dementia or multiple system atrophy. So that sign, when it occurs, heightens our vigilance for that patient, that we would want to monitor them more closely to make sure we're intervening as soon as we can with any motor symptoms that occur. And then other things like the loss of sense of smell, hyposmia is the fancy medical term for that. Mood changes can occur, 5-10 years before. And then even after the motor symptoms emerge, we continue to see evolution of non-motor signs and symptoms. And that's what we'll talk a little bit more about today, how those things might be affecting you personally and your quality of life. So we still rely on people like myself. And so far, I still have some job security on this front, because Parkinson's is still a clinical diagnosis that relies on us interpreting what somebody's telling us about their experience and the timeline of it, and incorporating what we're seeing on their physical exam with the history, and we use that knowledge to make a clinical diagnosis of Parkinson's disease. The diagnostic criteria for Parkinson's have evolved in recent years, and this Movement Disorder Society review article talks about recent clinical diagnostic criteria, and I don't expect necessarily that all of you are interested in this, but I just raise it to point out that we are recognizing the importance of non-motor symptoms and how that can dominate the clinical picture, and trying to incorporate that into our diagnosis in a way that hadn't been done historically. So we still need to see those defined motor syndrome in order to make the diagnosis, but we're able to use the non-motor signs as supportive criteria to confirm that someone likely has Parkinson's as opposed to some other cause of their symptoms. And I mentioned before how at this point in time, we can't take somebody who has constipation and say that their constipation is due to Parkinson's until we wait and see if those other signs show up. But this figure represents how we're trying to develop better biomarkers that would move Parkinson's a little out of the realm of clinical diagnosis into more objective criteria that could include spinal fluid testing, looking for different protein levels, looking at the saliva. We haven't developed any biomarkers there yet. We can test whether sense of smell is intact using basically like a scratch and sniff test of different scents. We can do a sleep study to see if REM sleep behavior disorder is present. So this just gives you an idea of the way that non-motor symptoms in the central and peripheral nervous system might be utilized to allow us to be more accurate in our diagnosis, or to identify people who are at risk for Parkinson's much earlier than their motor symptoms emerge. That would be important for us to do if we had a therapy that could slow disease progression or forestall emergence of the tremor and slowness and stiffness, which is kind of the holy grail of Parkinson's research. Pathologically, there's this important hypothesis that is discussed often in the medical literature, and this is called the Braak Hypothesis. And what this takes into account is that we think that the changes in the body, the nervous system specifically, that are the pathological hallmark that, in other words, dictate someone has Parkinson's disease, probably occur starting in the gut or more peripherally, and then climbing kind of up the spinal cord into the brainstem here, which would represent a early preclinical stage of Parkinson's disease where someone may not really have symptoms yet, and then growing over time kind of higher up into the structures of the brain and the basal ganglia, and then eventually involving the cerebral cortex, which might be the point at which you would have some cognitive changes or visual hallucinations and so on. So it's a hypothesis because we haven't quite yet proven that this is how it works, and there are some counter arguments to this, but I just use it to describe for you why we think the non-motor symptoms might emerge so many years or even decades before the other signs show up. So for this reason, the non-motor features are kind of the early clues that we now are recognizing better. So moving into kind of more practical information for all of you, I thought we'd talk about these common types of non-motor symptoms. This isn't a comprehensive list, but it addresses the most troublesome things that we hear about in clinic. I'd be happy to hear feedback from you if I've missed anything that's very bothersome to you personally. But I'll break this down into 4 categories. So we will talk about autonomic symptoms, psychiatric symptoms, cognitive impairment, and sleep changes. And we'll just discuss a little bit about our approach and management of each of these. Okay, so what is autonomic? The autonomic nervous system is kind of, I think of it as your autopilot. It's controlling all the things that we don't think about at all, such as blood pressure regulation, how food moves through our gut, and eventually how we have a normal bowel movement or not, how we swallow, how saliva circulates. You know, we normally don't think about whether we're swallowing and saliva is pooling. It just happens automatically. And also urinary problems and sexual function kind of fit under this autonomic umbrella. So when we have autonomic symptoms, it's kind of a failure of that autopilot, and it requires more engagement from us to control these things. So one really challenging problem is that we can see real significant fluctuations in blood pressure. And often this shows up as orthostatic hypotension. And that means that when you go from a lying down or sitting position to a standing position, there's a significant drop in the blood pressure. And this can feel to the person experiencing it like lightheadedness, or it can contribute to falls that occur, a few minutes after you've gotten up from a chair and started walking across the room. It tends to be a little bit worse in the morning. And just to add insult to injury, the meds that we use to treat motor symptoms in Parkinson's can drop blood pressure further. So, you might be feeling okay, and then you take your carbidopa, levodopa, especially if it's a high dose, that starts to kick in and drops your blood pressure. And that can either cause these fainting spells, or it might just make you feel tired and cloudy, like your thinking isn't quite right. And so those are symptoms that we have to kind of try to ask about, and it might prompt us to request of you that you check your blood pressure at home at different times of the day, before and after taking your medications, so that we can determine if we need to intervene further. So it's generally more bothersome for people to have very low blood pressures, and so we orient our treatment around trying to avoid those. And we also try not to have quite elevated high blood pressures on the other end, but sometimes the more immediate concern is the really low blood pressures. So for all of these autonomic symptoms, we take a similar approach, which is that we look at any factors that could be exacerbating the problem, and try to address those first. And that would include avoiding large meals, avoiding excessive alcohol, avoiding dehydration. So in other words, staying well hydrated. Things that can drop the blood pressure include like a long hot shower, because that dilates your blood vessels and drops the pressure, or just changing position too quickly. So we can try to educate people to avoid these potential triggers, and that might be adequate for some folks, and we don't need to go any further. If it's not adequate, we might try some additional measures, and we would try things that are not medications first. That could include compression stockings or elevating the head of the bed a little bit. There are some wedges that can be placed under the legs of the headboard, or sometimes you can use like a wedge under the mattress. And what that does is it kind of tricks the body. So normally when you lie flat in your bed, your body perceives that as elevated blood pressure and will react by producing more urine. And so people might have urinary frequency at night. They're diuresing too much at that point because their body is misinterpreting this lying down as high blood pressure. And then they get up in the morning and they're a little more dehydrated. The blood pressure is lower. They're more apt to have these low blood pressures. So raising the head of the bed can avoid that, can basically trick the body out of doing that. And sometimes when we've done these things, it's not enough, and we need to actually add a medication to elevate the blood pressure. First, we always are going to look at if somebody's taking a blood pressure lowering medication, we work with a primary care doctor to see if that can be reduced or eliminated. Sometimes people are on blood pressure lowering medications, not necessarily for hypertension, but for other cardiac issues. And, we can't get them all the way off of those, but we can keep them on the lowest dose possible. So that would be our first order of business. And then we might need to adjust the meds that are being used for the Parkinson's motor signs, because I mentioned briefly that the higher the dose you take in a sitting, the more that might drop your blood pressure. And then some of the medications for Parkinson's are more apt to impact the blood pressure than others. This is one instance where I have personally used the controlled release carbidopa-levodopa because it doesn't drop the blood pressure as much because it kicks in slower. I otherwise don't really love that medication during the day because it's kind of unpredictable and it's kicking in, but for this reason, it can be helpful sometimes. And then once we've done all those things, we might even add midodrine, which constricts blood vessels and raises the blood pressure that way, or fludrocortisone, which causes the body to hang on to more salt and therefore more fluid, or droxidopa, which also helps to elevate the blood pressure. So those are some examples of things that we sometimes need to add. Another type of autonomic problem is the GI dysfunction that occurs, and it really, we think about the GI tract from our mouth all the way down, and it can affect it at all levels. So one thing that people notice sometimes is drooling, and that is caused by a few different changes. One thing is that, I mentioned autopilot. We all are kind of swallowing without thinking about it a certain number of times per minute. And so even though we're constantly making saliva, it normally wouldn't pool because we're just always swallowing periodically to allow that to go down. In Parkinson's, though, that swallow rate decreases, and so the saliva can pool. And then on top of that, people often have a little bit of decreased facial expression. The mouth can be open more often due to the slowness that Parkinson's causes. And so not only is the saliva pooling, but the mouth is open, and that can allow saliva to escape. We have a couple different ways to address that. We can use atropine drops cautiously. Those are a little tricky because if too much of it gets absorbed into your system, it can cause some confusion. But a few atropine drops under the tongue can be a short-term solution. And then for people in whom this is a really bothersome problem, we can use botulinum toxin injections. And we typically just inject this parotid gland that sits kind of in front of the ear at the angle of the jaw. And that is adequate to reduce drooling for several months at a time. So that's if that's a problem that you have, you can ask your provider if they'd be willing to do the Botox. It is covered by insurance for this reason. It's a little uncomfortable. The Botox itself kind of stings a little bit, but most people tolerate it quite well, and that can be a good fix. Okay, so in addition to drooling, we can see dysphagia or swallowing dysfunction, and that can show up as taking longer to complete a meal, just getting tuckered out before you finish a meal, enjoying food less. Your family or friends might hear you coughing or choking on food. You can have some unexplained weight loss. And then when severe, we worry about aspiration pneumonia because of food going down the wrong pipe, so to speak, which is one of the things that is really a potential life-threatening complication of Parkinson's that we really want to avoid. And for that reason, we really, need to know if you're having trouble swallowing. And as clinicians, we're always looking for these signs like weight loss and so on that could indicate a problem that we need to address. So there are some things you can do that can increase the efficiency of your swallow. Pardon me. We can make sure that we're positioning ourselves well for food and drink to travel in the right direction. So you're sitting upright during all eating and drinking, tilting the head slightly forward, taking small bites, chewing thoroughly, basically all the stuff we tell our kids to do. So just revisiting those principles and trying to employ them. You can even make sure that you're swallowing twice for each bite that goes down. And it can be helpful to take smaller, more frequent meals, not only because this also helps with the blood pressure issue I talked about, but because then you don't get as tired, and it allows you to maintain a more even energy level. So we work with our speech language pathology colleagues to both address and evaluate swallowing problems, and we're often referring people for those types of studies. So if you are concerned about something like that, you can always ask your provider to refer you to a speech therapy consult for swallow and some treatment suggestions. Okay, so continuing on with our autonomic dysfunction, this is a really prominent problem for many people, constipation. And I would say more than half, probably 2/3 of people experience this at some point in the course of their Parkinson's disease. And sometimes it's attributed to the medication, but it's more often due to the Parkinson's itself. And we define this by, some of these signs that you might notice, either straining or having difficult to pass bowel movements, or fewer than 3 bowel movements per week. Any of those things can indicate a diagnosis of constipation. And, this can really decrease quality of life and limit, your comfort level with getting out, doing things, getting out of the house. And so it's something that we try to manage with a bowel regimen, because even if we correct it temporarily, it's typically going to be a long-term issue. So it occurs for a couple of reasons. One is that everything is moving slower in Parkinson's, including your gut. The peristalsis that occurs that moves nutrition through the gut happens more slowly. And because food is sitting in the intestines longer, more water gets absorbed out of that, helping to create the harder, more difficult to pass stools. In addition to that, we know that Parkinson's is associated with some changes in the gut microbiome. This is kind of a buzzword lately. We're hearing more about the microbiome and its role in different diseases. And so that probably plays a role as well. So in someone with Parkinson's, you might have what's called dysbiosis, where the just natural flora of the gut is altered in a way that's counterproductive for you. And so this can cause, decreased GI motility, increased constipation and pain, and that can translate to increased mood difficulties and behavior changes and agitation. So it seems like it would be a small thing, but it's really a big thing for many of our people living with Parkinson's. So lifestyle changes can be helpful. And again, taking that theme of avoiding things that exacerbate it, which would be like starchy and low fiber foods, dehydration, being too sedentary, other medications that you might be on for other conditions that can be constipating. And if those things are already being avoided and it's still an issue, then we want to emphasize the importance of fluid intake and fiber intake. Just a word of caution about fiber. In this particular setting, meaning constipation due to Parkinson's, fiber supplements work well for some people, but I'm always a bit cautious to recommend those, because if we're just, say, giving you Metamucil and things are still moving very slowly through the gut and that water is being absorbed, taking a bulk forming agent like that can just result in bulkier, still difficult to pass stools that can lead to a bowel obstruction. So if a fiber supplement is working well for you, then great. But if you haven't tried anything yet, it's often not the first thing I reach for that reason. But having a coffee, a tea, hot beverage, and just kind of planning to take some time for your bowel regimen every morning. We think about probiotics like, Activia yogurt, or you can buy probiotic supplements at the health food store. Things that have been fermented like kombucha or kefir can be helpful. And then exercise. And we really try to use prescription laxatives as a last resort. But if we need to, we absolutely can. And just a word about laxatives, we tend to, there are a couple links at the end of these slides that give more information about these different problems, including constipation. But if we need to resort to a laxative, we usually actually start with a stool softener first, and that can be like Colace, Docosate. We liberally use Miralax because that is not a stimulant laxative. It's just kind of an osmotic. It kind of flushes the gut out without causing cramping. So I would say my typical approach is stool softener, Miralax, and then if those things don't work, we might think about something more stimulant laxative like a Senna. And then there are a couple good recipes, one of which is on the WPA site for some power pudding. That's a combination of kind of fiber cereal, prune juice, and applesauce. Or we have another recipe that we give out for a fruit paste that incorporates dried fruit and senna tea. So those can be alternatives to taking another pill. Bladder changes also occur in Parkinson's, and the most common thing is that there's urination that wakes people up at night. That's a pretty common problem as we age anyway, but it tends to be more in Parkinson's than in non-Parkinson's folks. And nocturias, can really affect the quality of the sleep that you're getting. Urgency and frequency are also quite common, and those are usually signs that the bladder is a bit overactive. And then wearing off of your Parkinson's medication can contribute to these things. So sometimes if you're waking up frequently at night to go to the bathroom and your last dose of medication is at supper time and you're not taking anything till the next morning, adding something to bridge that time frame, like a dose of controlled release carbidopa, levodopa at bedtime, can actually help your sleep by cutting down on the number of times you need to go to the bathroom. Whenever someone's having bladder issues, I ask about constipation because we need to kind of address that first to allow the bladder to have room to expand fully. And those functions are kind of tightly linked. So sometimes just addressing constipation will alleviate bladder symptoms as well. And then occasionally we'll refer to urology. We work with your primary care doctor to make sure in men that say, prostatic hypertrophy or something like that isn't playing a role. In women, there can be, especially if you've been through childbirth, there can be issues there that need to be addressed. So we want to rule out other things and not blame everything on Parkinson's, but just recognize the way that Parkinson's can affect urinary function. One little point I'd like to make here, it can be put folks between a rock and a hard place because some of the medications that we use to treat overactive bladder can cause confusion and even trigger some hallucinations, which we'll talk about in a few minutes. So we want to use those things quite cautiously and judiciously and be thoughtful about our choice of which medications to use. Okay, so now we're kind of shifting gears, talking a little bit about the way that Parkinson's can affect mood. And this could be a whole hour-long topic in and of itself. So I'm going to touch on it briefly and then happy to take questions. But if you recall back to that earlier slide of the timeline of Parkinson's symptoms, depression and anxiety can actually precede motor features of Parkinson's for quite a long time. But, that depression and anxiety are so nonspecific that we don't necessarily recognize that it's due to Parkinson's until after the fact. However, sometimes treating depression and anxiety with some of the psychiatric medications can actually unmask or worsen physical signs of Parkinson's. So specifically, medications that are dopamine blocking, usually used to treat psychosis, but also used as a supplement for anxiety and depression. Medications like aripiprazole, which is Abilify, or olanzapine, which is Zyprexa. These things can, as I said, just unmask signs of Parkinson's because they block dopamine from working in the brain. Sometimes we are dealing with hallucinations and psychosis related to Parkinson's, and this is typically triggered by medications that we're using, and so it should prompt us to reevaluate your medication regimen. And impulse control disorders are another big facet of psychiatric symptoms in Parkinson's, and again, these are typically triggered by medications, especially dopamine agonists, which are ropinirole, retigotine, and pramipexole. And impulse control disorders comprise compulsive behaviors like gambling, over shopping, overeating, sexual addiction, things like that that are kind of a addictive type nature. But it can also be a little more innocuous, like maybe just spending a lot of time on a hobby that's a little bit unusual, or collecting things, that kind of thing. So we try to ask about that in everybody, but especially if you're on those dopamine agonist medications. Apathy is another thing that we often hear about, which is kind of just a lack of interest or motivation to do things, not necessarily tied to low mood. And then non-motor fluctuations, which is a really big challenge because this can be experienced by the person as really like dysphoria or a sense of doom or really intense anxiety as the medications wear off. And it can result in sort of over-medicating to avoid that horrible sensation of being off. So we do consider depression and anxiety as symptoms of Parkinson's, but we don't really have a Parkinson's specific medication to give you for it. So we work with our behavioral health colleagues. Health psychology in particular can be helpful because they can help you cope with managing a chronic condition like Parkinson's and really give you some good cognitive behavioral strategies to employ. And then medications can be really helpful too. And as I said, they're not Parkinson's specific. Like because you have depression and anxiety and Parkinson's, it doesn't mean that we always reach for this particular prescription. But we use things like venlafaxine, which is Effexor, or duloxetine, which is Cymbalta. Those are SNRIs that work on the serotonin and norepinephrine chemistry in the brain. And then SSRIs are probably the most commonly prescribed for depression, and those include things like sertraline, which is Zoloft, citalopram, which is Celexa, and escitalopram, which is Lexapro. Those are just some examples. There are many others. And those work on the serotonin system. And then bupropion, which is kind of in a class by itself and has some, that's Wellbutrin, and that has some effect on the dopamine system as well. So we try to look at the patient and what they're dealing with, whether maybe they're too sleepy or not sleepy enough, and or maybe they need to gain some weight. We might choose something that would allow that to happen more easily. So we kind of look at the individual when we're making a choice of a medication to use. Okay, so mood changes, moving on from that into more of the hallucination psychosis type of symptoms that can be pretty scary for people. Typically, these don't start out scary. They start out as very mild visual misperceptions of like maybe thinking someone's next to you and you turn and nobody's there, or thinking there's something moving on the floor, that you have a mouse in the house and you don't. So those are often the way that this might start. But if it goes unchecked, the hallucinations can become more well-formed visual, like of an actual person or an animal in your home or in your yard. Typically, people recognize that what they're seeing isn't real, or if a spouse or a family member or friend points out that it's not real, they are able to recognize that that's the case. But sometimes it can be a little harder to check. You've probably all seen this video. I don't know if it's going to play. There's a commercial for Nuplazid. This is kind of the updated version that unfortunately isn't playing, but many of you have probably seen it. Their first version of the commercial was quite scary, and I think a little bit manipulative, frankly, and no offense if any of our exhibitors are. But it really did prompt discussion, and people would come into their clinic appointments asking about it. So for that reason, it was a tool to open some discussion about what we expect to see. So Nuplazid is one example of a medication that can be used for hallucinations, but it's typically what we would do is revise the Parkinson's treatment regimen. So what we do is we streamline the meds in a specific order, taking away the things that are most likely to cause hallucinations without producing like a sufficient benefit to your motor symptoms. So for example, if somebody's on Artane or trihexyphenidyl for a tremor and they're developing hallucinations, that would be the first thing to go. Then we would take away amantadine, dopamine agonists, the monoamine oxidase inhibitors like rasagiline and selegiline, and then levodopa would be the last man standing, so to speak. So levodopa gives you the most benefit compared to risk. So in someone experiencing hallucinations, we'll often really streamline their Parkinson's treatment to only contain levodopa at the minimum required dose to manage their physical difficulty. So if we've done that and hallucinations are still there, then we think about adding a cholinesterase inhibitor like Aricept, which is donepezil, or the Exelon patch, or pill, which is rivastigmine. And then if hallucinations are still a problem, then we might add a medication like quetiapine, clozapine, or pimavanserin, which is Nuplazid. So, moving on from that, I know there's more to talk about there, but impulse control disorders are another category of psychiatric non-motor symptoms. And I mentioned what these can look like: gambling, spending, eating, and so on. And when these emerge and somebody's on a dopamine agonist, my personal practice, and I think many of my colleagues would share this, is we really just got to get you off that medication, because it's not a matter of willpower. It's literally like your brain cannot control. There's no brakes on that behavior, because dopamine is what our brain uses to signal to keep doing something positive. So in other words, you're at Ho Chunk playing the slots and you keep winning, your brain is sending dopamine as a reinforcing signal. And then if you start to lose, the dopamine is really shut off. But if we're giving you dopamine agonist medication, we're flooding those receptors so that they're tricked into thinking only the positive feedback. I hope that makes sense. So it's just not something that you can overcome by willpower. We really need to adjust medication. Impulse control disorders can occur with levodopa and other Parkinson's treatments as well, but they're overwhelmingly associated with the dopamine agonists. Then apathy. Apathy is, as I mentioned, really distinct from depression. People may not feel depressed, but still could be apathetic. And I think it's most frustrating to the people around the person, the apathetic person, like the spouse and or care partner, because it shows up just like indifference, basically, lack of motivation to do anything. And it can be problematic for managing the Parkinson symptoms, because someone experiencing apathy might not be as inclined to take their medications on schedule or get exercise, and we know how important that is. So apathy is a real challenge to address. We first want to make sure that it isn't depression, and then once that's been established, we can try some behavioral modifications. Sometimes we'll try like a mild stimulant medication, like Ritalin that you would use for a child with ADHD can be tried. Nothing that has been proven in clinical trials to specifically address this. It's kind of a individualized trial and error approach. And then we just try to educate families that this isn't the person's, fault. It's because of their brain chemistry that's changed. And sometimes that can be helpful in just destigmatizing it a bit. Okay, so what if you have these mood and psychiatric experiences, but they're cycling throughout the day in a pattern that matches with meds wearing off? And then we think about this concept of non-motor fluctuations. Non-motor fluctuations can feel like a panic attack. It can feel like trouble breathing, like you're short of breath, even though you're actually, oxygenating fine. There isn't a pulmonary problem. So this can take on a couple of different patterns, but it's something that we need to think about, and we would try to approach by smoothing out the medications, avoiding real highs and lows. It might prompt us to give the medication at a lower dose more frequently, or to adjust the formulation of the medication to be a more longer acting treatment for you. But that is something to be aware of, that it can occur and it can be quite challenging. So what about cognitive changes? Well, as much as I hate to say this, I want to be quite honest with everybody. Most people with Parkinson's will develop some cognitive changes over the course of their disease, but the severity of that can be quite variable. So some people might have very mild, if any, cognitive changes that don't threaten their independence in any functional way. Other people can have quite a severe cognitive change and can qualify for a diagnosis of dementia, which means that the cognitive changes are impacting their ability to function on their own, to do daily tasks. So this is something that we've recognized. It's well established now, but when James Parkinson wrote and defined what Parkinson's disease was, he didn't recognize the impact that it had on cognition, and he talked really exclusively about the motor signs. So this is one way that we've kind of come around to recognizing that Parkinson's comprises more than we originally thought, and that we need to address all its aspects. So what kinds of cognitive changes are you likely to see? Well, there can be fluctuations in thinking throughout the day, meaning that you could be very clear and sharp, especially early in the day, and maybe as you're more fatigued in the afternoon, that you don't feel like you're thinking as quickly or sharply. So we can, try to time cognitively stressful tasks in the early part of the day when you're at your freshest. I mentioned that the severity of cognitive changes is quite variable, and it's a little difficult for us to predict, especially like when we're first meeting somebody. But there are some clinical signs. For instance, if you had a diagnosis of REM sleep behavior disorder, we know those folks are at a little higher risk of developing some cognitive changes. If you have more rigidity and sort of akinesia, like less tremor, that can correlate with a little bit more cognitive change. But it's really tricky to predict. So sometimes when people ask this question in clinic, we might come across as being a little evasive, but it's not a lack of willingness. It's a lack of ability to kind of predict how this might go for an individual person. The types of cognitive changes are different than you would see in something like Alzheimer's, because it's not a problem with encoding new memory. It can be a problem with retrieving things like words or names or the name of a movie or what have you that is there. You might benefit from a cue, but it's not it's harder to pull out as quickly. Executive function can be impacted. Executive function means the types of tasks that require many steps, like planning a trip or doing your taxes or balancing your checkbook, things that are inherently a little more complex. Attention can be affected. This means that maintaining, like remembering what you were saying to give a speech without notes or something like that, or being able to say, like in clinic, we would ask somebody to maybe say the months of the year in reverse or count down from 100 by sevens. So you have to remember what you were doing long enough to continue the task, and that can be difficult. Visuospatial function can be impacted, and this might show up as, trouble getting your car into a tight parking space or something like that. So people often ask about the difference between Lewy body dementia and Parkinson's disease, and it's really somewhat arbitrary in that we call the diagnosis Lewy body dementia if the cognitive symptoms are present early and they're significant within the first year of disease. Sorry about that. If physical motor signs have been present for a year or more before cognitive symptoms emerge, then we call that Parkinson's disease. So it's really just a matter of the timing. And then moving on from that into sleep. So I'll briefly talk about that. I know we're running out of time. Sleep changes are quite common. Most people with Parkinson's have some kind of sleep disturbance. And it can be anything from being too sleepy during the day to having active dreaming to the nocturia that we talked about before. Sometimes sleep symptoms are actually motor symptoms in the sense that if you're wearing off at night, it can be hard to turn in bed and get comfortable, and that can impact your sleep. So we always want to rule that out. And then restless legs is a little more common among people with Parkinson's than the general population, and so that can be addressed as well. But sleep changes might prompt us to order a sleep study, or if somebody's describing pretty classic dream enactment behavior, like fighting an enemy in the early hours of the morning and thrashing around in bed, then even without formally diagnosing that with a sleep study, we might just simply try to treat it with some melatonin over the counter or clonazepam at bedtime. We want to make sure that wearing off at night isn't the issue with either urinating too frequently or having trouble turning in bed. So adding a little long-acting Sinemet at bedtime can be helpful. Sometimes we'll use sleep aids that help extend the duration of sleep, like trazodone is an example of that. So there are a lot of different strategies depending on how, when we're talking with you, we would troubleshoot it and try to hone in on the most likely cause of that. So in summary, non-motor symptoms are, even though less outwardly visible, they can be equally, if not more, impactful on the quality of life. And they occur due to changes in the brain and the enteric nervous system that start long before the motor symptoms arise. So this is really part of the process of Parkinson's disease. And we try to really take a logical, practical approach to management, which is eliminating triggers or exacerbating factors, employing lifestyle modifications, and then last but not least, adjusting and judiciously adding medication when needed. And so then I've just put some links here if you all have access to the slides. The various Parkinson organizations have really useful information on all of these topics that I've included there, but that's by no means comprehensive. So thank you so much for your attention. I think I just ended on time, and I don't know if there will be time for questions, but
I have a couple real quick questions for you, Dr. Mangin. This is Jeremy from the Wisconsin Parkinson Association. First of all, I'm sure you can hear the applause from everybody who's listening, so thank you very much. A couple real quick questions that came up during the discussion time. One was, can you describe or explain a little further what REM sleep means?
Oh, yeah, sorry. That would be my pleasure. REM sleep is just a stage of sleep where the REM stands for rapid eye movement. That's physically what's happening during that stage of sleep, and it's the stage of sleep where dreams occur. Normally during that phase of sleep, which you have several REM cycles throughout the night, but it's most prominent like in the early morning hours. And normally when we're dreaming, we can't move. But in Parkinson's, that paralysis during REM sleep is lost. And so you might be dreaming an active dream and you're able to actually move your muscles and thrash around, and that can be dangerous for you or your bed partner.
Perfect. one of the other questions that came up when you were talking about constipation was, is it common for people to have constipation and then extremely loose stool and then back to constipation, kind of maybe that roller coaster?
Yeah, unfortunately, we do see that for a couple of reasons. I mean, one thing is that we would want to make sure that that person isn't dealing with irritable bowel, which, unfortunately, Parkinson's doesn't prevent you from getting that. But sometimes if we aren't managing the constipation in a real, consistent way, that when the floodgates open, people can get diarrhea or loose stools, or you can get diarrhea around a blockage. And so working with your provider, your primary and your neurologist to address that can be helpful. And generally, if we are able to find a bowel regimen that you can be consistent with, then we can avoid those highs and lows. Perfect.
And then one last question I have for you, and it's one we get a lot of times, not only whenever we do this program, but also at support groups and other things. We discussed non-motor symptoms. How do you distinguish non-motor symptoms and how they're progressing versus some of the symptoms that look like just normal aging?
Oh, that's a great question. I mean, the short answer is it's not always possible to distinguish that, but we get some clues. I mean, I think this is where being a neurologist is like being a detective a lot of times. And so we would try to ask you the right questions to tease that out, and look at the nature of the symptoms you're experiencing, if they're consistent with Parkinson's, if they're fitting with your overall picture. So that would kind of take an individualized approach. Yeah.
Well, thank you so much for your time. We really appreciate it, and thank you for going through the technical difficulties we had at the beginning. For everybody who's watching, we are going to take a short 10-minute break. So at 10:10, we will come back. We will have our next speaker, Evan McNamara, who will talk about the pharmacist perspective. But while that 10 minutes is happening, as Gary said earlier and Dr. Mangin mentioned throughout her presentation, please visit some of our exhibitors, ask some of the questions you have of them, thank them for being here. Otherwise, we will see you in 10 minutes. Thank you very much.
Thank you, Jeremy. Thanks, everybody.